Jeffrey's getting everybody nice and comfortable. Hello, everybody. My name is Larry Kwan. I'm the CEO of St. Anthony Foundation, and I'm here to welcome you to our Addiction Forum, co-sponsored with the Salvation Army. These issues, right? Addiction, homelessness, poverty, these are the issues that our grandparents and parents were not able to solve. These are the issues then, by definition, the most complex issues in our society. And they deserve the smart people on this panel, in this room, to have dialogue and discussion. And that's why we've set this table. And at this table are 5 seats. Those with lived experience. Those that bring the wisdom and understanding of what it means to suffer from these. Those who are experts with evidence. They bring the data that allows us to understand and guide what should we do. The executors, those who are actually doing the care, right? They're the ones who know what it takes to be on the ground and delivering services. And then the 4th one, enablers of scale. The city, policymakers, the ones that set the rules and have the scale to bring it to more people. And the final seat, this audience, a community that cares. And so I want to thank you all for showing up and entering this very important dialogue. 3 rules. 3 rules so that we can have constructive conversation. Listen with humility. We have to come to the table thinking that the solution hasn't been found yet. We have people who are still addicted. We have people who are still homeless. Listen with humility. 2nd rule, remember our common ground. What is our common ground? The individuals and the community that are suffering from these afflictions. That's why we're here. We are serving them. And the 3rd, let's find ways to work together. Right? The conversation should find ways that we may not have ever discovered on how we can work together, because again, toughest problems in our society. Okay, with that, I'd like to introduce Reverend Richard Beal, who will kick us off. Up here, yeah. 30-year graduate of Father Alfred Center, and will kick us off with the understanding of what it is to recover.
Thank you, Dr. Kwan. Before I get started, let's have a moment of silence for those who have passed because of the disease of addiction and those who are still suffering, followed by the serenity prayer. God, grant me the serenity to accept the things that I cannot change, the courage to change the things that I can, and the wisdom to know the difference. That prayer right there changed my life. July 20th, 1995, when I first heard it. When I walked into St. Anthony's Foundation, I walked into Seton Hall at 165 Guerrero. I was taken there by a guy named Roy Washington. And he introduced me to the 12-step program. He introduced me to different principles of recovery. He introduced me to the saying, we're going to love you until you learn how to love yourself. And so I'm grateful for him. He has passed on. His nickname was Do Well. He was my counselor at Seton Hall, and I grew to have a lot of respect for that man. I got a lot of respect for St. Anthony's. I love St. Anthony's. I am a very, very proud 30-year alumni of St. Anthony's Foundation. And I'm talking about 30 years with no slips, no dips, no weekend trips. Yeah, I've been drug-free the whole time, and y'all told me when I came into St. Anthony's that you never had to use again no matter what. You know, I went through a whole lot of things, you know, from the time that I came out to San Francisco, from 1983 to 1995, 12 years. I had 53 detox episodes. But that last time when I heard that message from Roy, when he came to that detox NA meeting, he said, man, I got a spot for you at St. Anthony's. Do you want to come? And I was tired. I was done. And I said, yes. And so July 20th, I entered Seton Hall at 165 Guerrero. And I'm going to tell y'all right now, I graduated that program, and I still have my certificate. This right here is 30 years old. That's the original. And then I completed that program, and they let me go to Covenant House at 818 Steiner. And I completed that program, and this is that original certificate. You know, so I'm a real 30-year alumni. And I need to say, after I completed those programs, I made a decision to join the Army, Salvation Army. I went to 242 Turk Street. I know it's the Kroc Center now, but at that time it was Bridgeway Transitional Housing, and I stayed there for 3.5 years. And it was a requirement that I went to 2 meetings a week, and 2 meetings they had right there on site. And so it was easy to get connected to the 12-step program. They said change is hard, but it's the resistance to change that makes change hard. And you need to embrace the spiritual principles of recovery, like faith and hope and acceptance. But most of all, you need to embrace the spirit of love. You know, and so that's to me, that's the whole thing about recovery. And I know that, you know, addiction is a biopsych, social, and spiritual disease. So we need a biopsych, social, and spiritual solution. But I need to say that recovery for me is about a spiritual transformation. And that spiritual transformation comes from applying the spiritual principles of recovery into your life. I'm talking about actually living recovery. And I'm talking about I have learned how to embrace people beyond their faults, beyond their failures, even beyond their behavior. I know a wise man once said, he said, no greater commandment than I give you that's greater than this, that you love one another. By this, the whole world would know that you are my disciple. I was taught a whole lot of things during those first 4 years of recovery, of being connected to St. Anthony's and being connected to Salvation Army. And I need to say that the most important thing that I learned was to embrace the still suffering addict, and that the therapeutic value of recovering addicts and loving one another is unparalleled. The therapeutic value of one addict helping another is unmatched. And nobody cares how much you know until they know how much you care. And they told me behavioral outbursts are mental, emotional, and spiritual opportunities for growth. And so they said that we expect you to act out in behavior. And then that's an opportunity to address that character defect. He said, one thing that he taught me when I went into the primary program that helps me today, he taught me a saying. He said, just finish this sentence. My recovery is in trouble when I. That was it. All the things that I learned when I was in Seton Hall, Roy Washington taught me, he said, my recovery is in trouble when I, and fill in the blank. That right there got me through that first 5 years of recovery. I was able to identify my character defects and work on myself. But I need to say, if you're here today and you're in recovery, you never have to use again no matter what. And I only got 2 rules when it comes to recovery. Rule number 1, don't take nothing. Rule number 2, never forget rule number 1. That's it. Trust God, clean house, help others. That's the script. Trust God, clean house, help others. So recovery is about love. And today we're going to talk about what is love in action. What is love in action? You know what love in action is for us? Love in action is shutting down those open air drug markets. Love in action is opening up more residential treatment beds. Love in action is making it mandatory for people to participate in support services and permanent supportive housing. I'm talking about love in action. Sometimes you got to practice. Sometimes you got to hold people accountable. That's called what we call tough love. Because I will hurt your feelings to save your life. And so we are here today. You know, we're going to hear from the doctors. We're going to hear from Steve. You know, we started the recovery working group together in 2019, and we're still here. We're still on the path. We're still on the mission. They call me the ambassador for recovery because I cross all bridges and break down all barriers because I'm serious about addressing the disease of addiction and helping the still suffering addict no matter what. No matter what. And so I show up and I show out. A lot of people say, well, you know, I like my voice to be loud because a lot of people are dying in silence. So HOPE stands for hearing other people's experience. HOPE stands for hold on, pain ends. And for St. Anthony's and for Salvation Army, HOPE stands for helping other people eat. I'm grateful. I'm grateful for St. Anthony's. I'm grateful for Salvation Army. I'm grateful for the friends that I have in recovery. My name is Richard Beal. I am the ambassador, a proud 30-year alumni of St. Anthony's Rehabilitation Program. Thank y'all. Let me introduce Dr. Humphrey. I apologize. I want to bring to the stage, put your hands together, y'all, for Dr. Keith Humphrey, our moderator for the day, y'all.
Thank you. Thank you so much, Richard. Nice to meet you all. My name is Keith Humphreys. I'm a professor at Stanford. More importantly, I'm on the board of St. Anthony's Foundation, one of your two hosts today, and I'm really honored and happy to get to moderate this very distinguished panel's thoughts about recovery. So let me start by introducing them to you, and we'll just go right down here. So immediately on my left is Dr. Paula Lum. Paula is a physician and a professor of medicine at UCSF and at SF General. I have been working in the addiction medicine community in the Bay Area for 30 years or so. I have never met anyone who doesn't think the world of Paula Lum, both as a person and as a professional. And that's impressive because we're a cranky bunch. So you're very popular. Kunal Modi, you know how there's some certain type of mother who's just so proud of her son she can't stop bringing him up in every conversation? That summarizes St. Anthony's relationship to Kunal Modi. He did so much for us, helping us become a better organization and then serving on the board, and we're just incredibly proud that he's moved on now to be the chief for Mayor Lurie of Health and Human Services. Next to Kunal is Dr. Terry Osback. It was a really happy day for St. Anthony's when he became our chief medical officer. He's extremely experienced as a physician and a leader with lots of different populations and settings. We're very fortunate to have him, and also, of course, he is overseeing the Father Alfred Center, so he's expert as well in addiction medicine. And so, glad to see you, Terry, yeah. Next to him is Steve Adami. Steve is a force of nature, I think. You know, I'm always interested in what he has to say about recovery. He's been a tremendous advocate, both in terms of relating his own experience and helping other people find recovery. I've been over to the Salvation Army a couple times recently. The place is really hopping, just building more and more programs. You feel tremendous energy there. And Steve is absolutely central to those efforts. He's just making a big contribution to this community. So thank you, Steve, for being here. And then we're also very lucky to have Dan Tsai here. So Dan has a very distinguished record. He was the longest serving Medicaid director in Massachusetts. Then he moved to Washington, D.C., the agency that oversees Medicaid, Medicare, and many other things besides for the whole country's healthcare system. And that he came out to San Francisco is, I think, a great blessing for the city. He is now our director of public health, and really appreciate him being here today. Thank you, Dan. Okay, so let's get right into it. I thought I'd start with our physicians with a question. So we'll start with you if we could, Paula. Say someone comes into your office and says, you know, I'm really struggling. I've been drinking a lot. I'm using a lot of cocaine. My family's really mad at me. I lost my job. I can tell I'm in a bad shape. And I've heard people say, you know, you'd be better off if you were in recovery. And so I just wanted to know, what is that? What do you say? You're not
Can
on.
you hear me? Yeah.
There you go.
So I guess the first thing I'm going to say is you're in a bad way and you're thinking about making a change. And thinking about making a change is the first step in recovery. What else would you like to know?
Patient has a second question. Patients always have a second question. I went through a dark time 5 years ago. I was really depressed, and I was actually hospitalized, and they put me on a medication, an antidepressant, and I still take it. Can I still do that and be in recovery?
Yes. If it helped you, yes. If it didn't help you, why?
Thank you, doctor. Let's
I'm
now.
not a psychiatrist, just saying that. Pass it to Terry.
So, Terry, same question. Someone comes in, my life's upside down. I've heard about this recovery stuff. I've heard about Father Alfred. What is this recovery thing? Why would my life be different? How?
So, first off, I think recovery is a very interesting word. It implies that we've lost something. And by the time someone comes to one of our offices, they've not just lost their ability to control their use of drugs. They've often lost their house. They've often lost their family. They've often lost meaningful work. In the worst case, they've lost their health. They've lost their self-respect. And for a lot of people, they've lost hope. So when they come to me and they want to know, what is this about recovery? I have questions for them. And the first question is, what did you lose? And the second question is, how can I help you get it back?
Terrific, Terry. And then again, the second question, Doc, my problem's with fentanyl, and I've heard there's this medication called methadone that people take. Can I take that and still be in recovery?
The simple answer is yes. Every addict has a pathway to health that is different. One of the things that we feel like that is special about St. Anthony's is that we try to open up as many pathways as possible for someone to walk down that path of health. That includes medically assisted treatment. That includes psychiatric medications if they're indicated. It includes methadone if that's what's needed. It includes whatever it will take to help that person walk down that path.
Thank you, Doctor. Steve, similar kinds of questions, although say a person adds, I know you're in recovery and I can see your life is better than mine in every way. I'd like to have what you have. Tell me, what is it like? Where am I headed?
Thank you, Keith. You know, typically when people ask me questions about my life or recovery, I try to do what Terry does and start asking them questions back. You know, it's really getting clean. People have this misconception that drugs are a drug addict's problem when we do drugs quite well. What we don't know how to do is live life. And when people come in and start talking about recovery and how you get your life together, you know, I was one of the fortunate people that got clean in a set of handcuffs. So nobody locked me up because I was a drug addict. They locked me up because I couldn't follow the law. And when people come to me and ask me about recovery, I try to just get them through the next moment. What brought them there? Where are they staying? When was the last time they used? What do they need immediately? And try to get them into a safe environment, free of drugs, get some rest, and then at the next phase, when we start talking about what they want to do with their lives and what they could think they can commit to. You know, recovery is a lot of work every day. And to me, like Richard, it's a deeply spiritual journey. And through the journey, you begin to heal emotionally and your well-being improves. But the transformation doesn't really take place until you really start to learn how to live. Because like I said, drugs were not my problem. My problem was I didn't know how to live life. So it is an independent journey, but it has to start when the individual decides to abstain from drug use. So there is no recovery while you're actively using. I know there's an ongoing debate about that in San Francisco right now, but for us, for me, for my friends, my peers, recovery really begins when the person decides they've had enough, they've hit some bottom, and they need a springboard back to a new life.
Thanks so much, Steve. Very well said. So let me ask you, too, the second question. Let's say someone is not using any illegal drugs at all, but they are taking a medication like an antidepressant or like methadone. Is that recovery?
Yeah, sure. As long as they're not using illicit street drugs, definitely recovery. There is one thing, though. I've been to a ton of programs throughout my life, in them, ran them, designed them, and I think people can be on medication-assisted treatment. I think it's, especially in today's modern era of fentanyl, but we require that people are present in their own life. So they can be on medication-assisted treatment, but it is really, really important to monitor the dose. I'll give you an example. In the mid-90s, if you're a heroin addict and you decided you want to go to treatment and you're on methadone, you were lucky if you could get it for 2 weeks and get 40 milligrams a day. Today, I know a woman that was in one of our programs. She's 110 pounds on 190 milligrams of methadone a day. And, you know, so I'm not a counselor, I'm not a case manager, I'm a director, I oversee a bunch of different programs, but I saw her nodding out, and I just went over to ask her if she was okay. I didn't know if something was wrong with her, and she was talking about methadone, and she was talking about the need to come off methadone, and that her doctor was actually actively talking to her about not coming off methadone. That they said that she would likely relapse and OD and die if she came off methadone. So I rolled up my sleeves like any good former criminal would do and say, listen, it's going to be okay. Medical doctors are not the solution to our problem. You're the solution to your problem. And with a group, solid group of peers, you can come off of methadone, you can reclaim your life, reunite with your family, raise your children, and really retake back your place in the community. So I do want to say, I think Richard did an amazing job, but like, I just want people to hear, if you hear nothing else from me, drug addicts can get clean. You do not need a PhD.
Thank you, Steve. So let me turn to our distinguished civic leaders. Let's start with you, Dan. As you know, the Matt Dorsey has passed a resolution for recovery. The mayor has said, yes, this is our highest goal. You have to think about this differently than someone who's working one-on-one with patients. You have to think about your department, what's the mission, and for the whole city. So when you are trying to promote recovery, what do you think of as, this is what I'm trying to do, this is where I'm trying to get this city?
Hello. So, I mean, I'm the newest person here in San Francisco, and I was planning on taking 6 months off after I finished in the federal administration. And then this thing came up, and I thought it'd be an easy walk in the park with all you all, so here I am. And it has been quite an education in San Francisco politics, the stakeholders. The positive piece, many things are positive. I've been in my job just over 6 months. I love it. I'm out in the street a lot. I'm walking around. I'm seeing what's happening, and that energizes me in a way like nothing else. But one of the things I would say about the intense debate that this community has had, this broader community in San Francisco, around how to approach drug use, recovery, treatment, harm reduction, all of these pieces. It's been so divisive in many ways, and from my standpoint, we absolutely can and must do more. That doesn't mean, it's not an or, that doesn't mean throwing out what we know around a whole set of evidence-based healthcare related pieces that there's a lot of literature and practice on. It also doesn't mean accepting that the way our streets look, the 2 people dying a day of overdoses, the amount of untreated or undertreated both mental illness and addiction does not mean that that is acceptable and that we can't do more. And every time I think we're making progress, which we are, I believe, in this kind of new era that we're in, I walk the streets, I'm out, many of us are out, and you see the amount of pain and suffering and challenge on the streets, and it reminds us every single day there is much more to do. And last thing I would say on these short little vignettes is part of what we as a city, as a Department of Public Health, can and do more of, and we're pivoting substantially on, is everything we do needs to operate as a system of care that is thoughtful and compassionate and meets people where they are at, but has a proactive intention about helping someone move from where they are in the street, in crisis, using, to that next step, as you heard from some of our colleagues and folks with lived experience. And we, as a Department of Public Health, as a city, have had many amazing clinical assets and partners and programs all across the city and county. They have not always been organized with the intention of meeting people where they are, but also helping people move forward in that journey of treatment and recovery. And it is often incredibly difficult to navigate from one part of our program right off the street to the next, to the next. And a lot of what we're trying to do here is to work with not only the Salvation Army, St. Anthony's, many others, to actually build a continuum and a system of care that can move folks along that treatment and recovery journey, that has a proactivity built into every interaction, every clinical engagement, every setting of care, is dignified and respectful, but also believes that recovery is possible and that more is possible. And that really underlines, I think, how we as a team are really operating and driving forward.
Thank you, Dan. Kunal, if I could ask you to build on that, you are an expert at organizational management and measurement. So as the city is pursuing this goal, how will you know concretely that you are succeeding, failing, or staying in place to promote recovery in San Francisco?
Well, the first step is being very clear on what problem we're trying to solve. And I think for many years in San Francisco, we use the term homelessness, and we all mean different things. And we're clear that we do have a homelessness crisis, but what we're seeing, the suffering that Dan alluded to on our streets, is also largely a drug addiction crisis and a behavioral health crisis. And so we're trying to be more clear-eyed about the intersection of those three and the prominence in particular of the drug crisis and the behavioral health crisis today. So starting with that is the first step. The second is, as Dan said, thinking about what is that continuum of care to help someone who's in crisis on our streets actually make it through to the other side. What we've historically done as a city is focus a lot on low barrier shelters. We have 50 low barrier shelters that have about 4,000 beds in them, or permanent supportive housing. We have 150 permanent supportive housing buildings, over 13,000 units. But bringing someone indoors is a first step, but too much, housing first has become housing only in California, and the reality is the need on our streets is much more extensive than that. So what are the clinical supports, the behavioral health supports, the addiction recovery structured programming that actually help people overcome the challenges that they're facing and know that it's possible to achieve recovery? And then the last point I would make is just to be clear about what our objective is. We have been focused for many years on keeping people alive, and that is essential and that is critical, but that is too low a bar. The goal is to help people achieve self-sufficiency, to achieve abstinence, to lead healthy and fulfilling lives, and we're trying to raise the floor to what we should actually want for anyone who's struggling on our streets today.
Very, very well said. We're still real proud. I want to talk about models and systems. Okay, so we've actually had pretty high agreement on what we're trying to achieve. Now we got to figure out how would we actually do it? Like what models will bring more people to a state of recovery, and then what systems have to be around them so that they all integrate with the other kinds of things we're trying to accomplish as a city. And Steve, you're doing so much at Salvation Army. I thought I would start with you. You've got the Way Out program. You have a lot of others. What, in your extended experience, are the models that move people into recovery?
Well, thank you, Keith. I think there's one thing that Kunal and Dan left out, and it's the intersection of drug addiction, homelessness, and crime. I know for myself as a career criminal that there wasn't a day that went by that I didn't break the law. And so when we look out on our streets and we spend about, $1.5 billion a year on behavioral health services coupled with housing services, and then we look out on the streets and we have 8,000 people living on the streets, we've killed 4,000 people to overdose in the last 5 years, that we have to say, like, something is clearly not working. And I think the first thing is to be able to have open and constructive dialogue about what's not working and have the bold approach, like Kunal and Dan and Mayor Lurie, to say we're going to enlarge the solution space and we're going to try some new things. I think we've kept people sick for far too long. So our work at the Salvation Army, the Way Out is an initiative. It's focused solely on the intersection of drug addiction and homelessness. We currently have 9 programs, 511 beds, that does 3 primary things: get people off the streets, get them off of drugs, and teach them how to live. We've had incredible success. We launched a small pilot 2 years ago, and we added another 100 beds in the Mission District. And what we've learned is the people that we get off the streets, that go into treatment, that go into post-treatment housing for a couple of years, we've had a 77% success rate, which is absolutely phenomenal. I do like Dan and Kunal, so I'm not beating them up. But I want to say there's an article published in December, and I want to get back to, we spent $800 million a year on behavioral health services. That is a lot of money. And in December, it was published that San Francisco has a 12% completion rate. So that means 88 out of 100 people in licensed residential treatment in San Francisco fail. We clearly need new applicants to respond to RFPs. We need new treatment providers. We need new approaches. We probably need to talk about expanding Medi-Cal, expanding models of treatment. You know, what Medi-Cal did, and I know Dan is a big fan of Medi-Cal, Steve Adami is not, and I'm going to explain why. Not because it doesn't bring a lot of money. What Medi-Cal did to treatment is destroyed it. And here's why. Treatment is about community. It's about me being part of a larger community, and we're all going up the hill together. I'm a proud Delancey Street graduate. I was there with 500 of my peers, and we supported each other. If you go to a Medi-Cal funded treatment program, it's not about your peers, it's about the relationship with you and your doctor, and you and your counselor, and you and your clinician. So instead of all operating together in a community, you've got 80 people living in a building and nobody's doing really well. So I really want to get back to the old therapeutic community model delivered through evidence-based practices, because I think the value of a community is essential. That is why homeless encampments are so successful. They're all out there living in a tent, shooting dope. We allow them to do that in San Francisco. So why would anybody quit? And they're all out there hanging out with their friends, destroying our streets. I do want to give the mayor and his administration, Dan and Kunal, you know, acknowledge the work they've done, because it's not been easy. I've been in public meetings with them, and people are taking out their frustrations of the last 10 years on these guys, and they've been very steadfast in their approach and are really prioritizing recovery. And I just want to say thank you, because it's really difficult, and I've seen some of the stuff that you've had gone through. So it is nice to work with them. But Keith, we need models that help people reclaim their lives. We should not be funding models that enable addiction.
Thank you, Steve. I'm very curious, Dr. Lum, so what models do you think help people get into recovery?
Many different models are needed. Many pathways are needed because there are many different types of people out there. There's not one model that's going to fit every single person. And so I am so appreciative of programs like Father Alfred, St. Anthony's, Salvation Army. You know, I work at San Francisco General, and I'm desperately trying to get people into treatment. I can start them on treatment, but where do they go after that? It is a gift to be able to refer patients to residential treatment if that's what they need and if that's what they want. There are some people that don't need residential treatment or don't want it. And so when they do, if they do agree to go there, sometimes they get out of the taxi cab on the way over, right? Or sometimes they get there and they're like, I thought this was housing, but actually this is more than I bargained for. So we need to find models and pathways that take care of people who are not ready for residential treatment, right? There are so many different like colors of the rainbow, right? There's many people out there that need different solutions. And so that's one of the aspects of recovery that I think most of us can agree on, is that there has to be many different pathways. There needs to be a menu of options. One of the facilities that I work at, the outpatient buprenorphine induction clinic, they had a motto, is every door is the right door, because at least you're heading towards the door and you're walking through.
Thanks. Did you want to get in on this, Dan? I couldn't.
Hello? Paula, can I ask you a question? You made an interesting point. You said that there's a lot of pathways, and you said a lot of people need different stuff, and that you said that you've referred people to treatment, they got there, and they thought it was housing, because this is something that comes up a lot in the community. I think we have $80 million in outreach workers in San Francisco. They never talk to people on the streets using drugs about treatment. The only word that ever comes out of their mouth is housing. As somebody who's shot dope, lived on the streets, been to prison, I also got a master's degree, and the worst part of my life, I was a menace, and people would have offered me housing. I am never going to get clean. I'm going to take free housing, and I'm going to shoot dope until the walls fall off. So when people tell you, Paula, I am not ready to stop using, and I am not going to go to treatment, as a medical doctor, what do you say to them?
Well, what can we work on, right? So what are your goals as a patient? If you're going to continue to use, how can we keep you alive? How can you use more safely? And where are you going to go next? A lot of them are questions that I'm going to ask a patient, as opposed to, well, then I have a plan for you, right? So kind of want to bring it back to this whole conversation we're having about recovery and what that really means. And I know there's been a lot of conversation about what it really means, and that definition, or that working definition, has evolved over many, many years. Something that I look to is a working definition that was developed by the Substance Abuse and Mental Health Services Administration back in 2010. They're also known as SAMHSA. And they saw this problem, 15 years ago as well. And what they did is they collected people in the behavioral health field, including people who were in recovery from mental health and substance use problems. And they did a lot of work to find a common, unified working definition of recovery. And this is for recovery from both mental health disorders and substance use disorders. And their definition is recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. That's it, right? I mean, there's nothing in there about abstinence, which may irk some folks. In my experience, often abstinence is required to get to certain places. And then they went on to describe 4 major dimensions that support a life in recovery, and that is health, home, purpose, and community.
Can I just ask one follow-up?
Actually, Steve, I'd like to give some other people just a chance here, so go ahead, Kunal.
This is just important, because this is really why we're here today. Because I just want to ask people in recovery if you can smoke fentanyl safely, because that's what this is really the crux of some of the challenges that get me and some of my friends very charged about enabling addiction. And our belief, I'm a very below average person. I got a master's degree. I have a published article. I was a director in a law enforcement agency after I got clean, and was there for a decade. And again, I want to say I'm below average. And I think it's very dangerous to talk about people that are addicted to drugs, about using drugs safely. Because I don't think anybody can use fentanyl safely, or perhaps we wouldn't have had 4,000 overdose deaths in the last 5 years. 25% of them didn't happen on the streets. 25% of those happened in government-funded permanent supportive housing.
This is, there's a lot of nuance in the issues we're talking about, but the one thing that isn't nuanced is there's nothing safe about using fentanyl. And we just have to be clear-eyed about how fentanyl changed the game. This is not heroin, this is not prescription opioids, this is 100x the potency. And every time you're using fentanyl, you're playing Russian roulette. And so we really have to think about, what is the best productive way to get people to break their addiction to fentanyl and be on a path of abstinence from what is a dangerous drug that has taken too many people in our community. You know, one of the things we really want to make sure, as Steve said, is that we are, anytime we're supporting someone who's trying to break their addiction, that we're actually surrounding them with the wraparound care that will actually help them get to the other side. It's actually 26% of overdoses happen in permanent supportive housing. And that's unconscionable. We need to, you know, the elements to recovery, as you said, are safety, their hope, their structure, their supports, there's clarity on what the next step is. And too often we haven't layered in those additional services. A lot of our inventory today as a city, and one of the things Dan and I and a bunch of our colleagues are rapidly trying to change with partners, like many of you in this room, are think about it more than housing and low barrier case management, but more intensive case management, clinical services, behavioral health care services, treatment services. Someone wants to break their addiction and, you know, achieve greater stability, we can help them. But that's not what we've historically been doing. We've been trying to get as many beds as possible and make sure someone gets inside, but we haven't paired bringing someone inside with the types of services that will help them achieve lasting recovery. And so that's what we're really focused on. Our goal is to help people be healthy, and that's what we're trying to do here.
And I want to ask, Kunal, just to follow up. So as a systems thinker, how do you get all those services? We have so many, with so many contractors, to actually work towards what you just described as a system.
You know, what Steve makes a good point. We've spent a lot of money in San Francisco over the past several years, and we have had a more is more mentality for many years. And we're trying to step back and look at the entire system and care and say, we need to think a little bit differently. While we have scaled a lot of inventory, we always haven't scaled the right types of beds over the past several years. And so we're trying to fill in those gaps. The first 24 to 48 hours of crisis stabilization, in between spaces, so it's not always an emergency room that's overcrowded or a jail that's not equipped to help someone, but it's a structured program that provides the right amount of structure, but actually treatment and care. More step-down beds so that when you complete a drug treatment program, you have somewhere to stabilize as you get on a path to workforce and stability. And so we've been very focused on adding the right beds at a higher level of clinical intensity, converting many of the beds that we have today, and selectively divesting ones that haven't been serving us well by looking at the data and understanding what works well. And that means we have to be more thoughtful around how do we organize the system. We do this work through several partners and contractors, and that's a logical thing. Behavioral health care and social services work is not some big commercially profitable enterprise, so it's not like one of our big health systems, like let me run all your beds. So it's always going to be this mix of philanthropically and publicly supported organizations that do this work. But that doesn't mean it has to be as fragmented as it is today, or as apples and oranges as it is today. We as a city need to do a better job of establishing clinical standards, health standards, programming standards. We also need to be a better partner to our contractors. We have a lot of work to do on the city side to do better contracting and invoicing and outcomes measurement. And then we need to collectively hold each other accountable. And so those are the things that we're trying to do. The right beds, the right measures, the right programming, and then the right partnership with contractors to achieve that.
Thank you. Thank you, Kunal. Terry, I want to let you get into this question of models. You're overseeing a treatment program. You've overseen many. What is it that you think are the essentials for a program to be good at moving people into recovery?
So first off, I want to make one admission, which is that I am a psychiatrist, have been for 40 years.
No one's perfect.
Have worked in the public system that entire time. Have managed, run, worked in multiple different programs. And I wish I had an easy answer. I wish I could say, this is the model that works. This is the model that is the most successful. We need to offer people who are addicted an option to the community they've established on the streets, an option to a life that involves crime, involves constant use of drugs, involves hopelessness. What that means is immediate access when someone is ready for treatment, when someone presents to the door and asks for treatment on that day when they're ready. If what you give them is a piece of paper that has a bunch of phone numbers on it that they can call the next morning, that's not treatment. That's not access. So I think the first criteria is immediate access. I agree with what everyone else has said about a full continuum of care. I don't think there's any right way, but I do think that we need to walk beside people. We need to treat them with respect and compassion, and it needs to be wraparound services that are long-term in nature, because a 30-day program is not recovery.
Thank you, Terry. Dan, you have to put these services together in your department. I'm just curious, how do you think we build a system so that all the models that are being discussed and other models we may need work together? And also, are there any pieces we're missing right now that we need to add?
Yeah, so I think I say this with affection and respect for both ourselves, DPH as a provider, and our CBOs, but we don't have a system of care today, and that's been very apparent through a range of pieces. And what I mean by that is part one of a system for tackling behavioral health homelessness as crisis is when somebody is on the street and is ready for any sort of change, for treatment, to take that next step that Mr. Beal and Steve talked about. It is most often very complicated to figure out how to do that in a way that's going to help someone proactively move through a treatment continuum. The other day I was on the street late in the evening. I actually called Kunal right after we were chatting, but I was with somebody who in that moment was ready to start treatment. It was after 10 p.m. I was on Mission and 6th, and at that exact moment, I did not have a place to get that individual. And so I got his phone number. Actually, he gave me his mom's phone number. He told me what deli he was going to be at on Ellis Street the next day, where he was going to be in the evening. Our street team went out to find him, got him into program. He then decided he was going to come out. We then went to find him again. But my point being, we do not do a good job at quickly getting folks into that upfront tip of the spear piece. The other thing then for a system that we don't do well on is once you get in the first 23 hours, we need to be able to get you into actually a range of treatment, potentially residential treatment. And for folks that are graduating from residential treatment to have a place to step down, we have a lot of folks that finish residential treatment, and you know where they go? They go back out to the street. And we've just spent a ton of time. They have made a lot of progress, and they start at square one. And so when I look at that, in my first few weeks, it took about several days in front of a whiteboard. The team just wrote acronyms for me and explained all the things that we have here in San Francisco, which is a plethora of amazing pieces that don't fit together as a system whose job is to meet people in a range of different situations and quickly get them off the street and into the next thing and into the next thing in a way that does not have all of these barriers. So fundamentally, what we're trying as a department, and I would say this is not just inclusive, this is not just DPH, this includes HSH and thinking about all of our assets, including housing, together. We need something that flows through, and we also do not do well when there's any sort of complexity of mental health complexity, behavioral complexity, and actually getting people through. So those are all things that we lack and have major gaps at. One of the things that we've just been debating a ton of, and why I think we've partnered in a different way than the city ever has before with the Salvation Army, is because you have a whole part of that continuum from right off the street to Harbor Lights with residential treatment to where folks can graduate to with residential step down at the McPhee and also the Marina Inn that just opened up. We are trying to replicate more of that sort of continuum approach, and people can move forward and backwards, but there's got to be a place for folks to get to versus individual siloed pieces where it's really hard to get from one place to another. And when folks need to move forward or backwards, there's no place to go often. And that, unfortunately, is the reality of how we've often approached things here in the city. And that's what we are. I mean, we have made substantial pivots even in the past 6 months. And the types of treatment beds and capacity and supports we're doing are all in line with having a view of what we need to do to help move people in a compassionate but systematic and proactive way from the streets through that journey of treatment and recovery.
Thank you, Dan. All right, so we have about 3 minutes left before we move to Q&A. So I thought it would be a nice way to close, since we're talking about things that are very sad and painful, to close with some optimism. So I'm just going to go right down and ask each of you just to take 30 seconds or so to say one thing in the midst of the suffering you've seen gives you optimism about where San Francisco could go. I'm going to start with you, Paula.
Well, the easy thing is that we're here right now having a conversation, right? And so that there's a willingness and a desire and a drive from partners all over the city, whether it's the city leadership, nonprofit organizations, the academic institutions, the hospital, to work together. Yeah, and that's what we need to move forward.
Thank you.
So I think over the past several months, there has been a broader awakening across our community about just how urgent this crisis is. Many of you in this room have been ringing the alarm bell for many years and been doing the work on the ground. But it feels like finally a lot of the pieces are coming together. A direction we're trying to take at City Hall, set of partners, our broader community, the philanthropic community coming to the table to support this approach. And so I feel like there's a level of alignment and clarity of purpose on what we're trying to solve. That gives me a lot of hope. And then frankly, just, you know, a part of this job is you spend more time than on the streets or visiting programs. And I've just met many people who have gotten to the other side of those programs. And so they will say, I was that person you see on 6th Street who was folded over, struggling, wasn't sure I'd make it to tomorrow. And then you're sitting across from him and you're like, wow, that's, if we could do that many more times over, that's, you know, what we're really here for. The one other thing I just wanted to add, Keith, is, you know, as we've gone through this whole panel, we focused a lot on the people who are in crisis on our streets, rightly so. But one of the things we're trying to take very seriously is the mandate of public health means the whole public. And so that also means our broader community, the 800,000 San Franciscans. The other day, I was walking in the Tenderloin, and I just happened to end up a few paces behind a mother holding her daughter's hand. She looked about 4 or 5. And I was, you know, probably walking alongside them for 4 or 5 blocks. And the daughter passed 4 instances of public drug use. And so we are trying to think both how do we support those who are in crisis, bring them indoors, but also think about the trauma of that young child. How do we make sure that we're realizing that, you know, public drug use, that what we're seeing on our streets is equally traumatic for them, and we owe them better too. And so we are really trying to think about the whole public.
It gives me a great deal of optimism that we're talking about this, that we have this group of people at the same table trying to problem solve, trying to come up with solutions, and that we have this many people supporting us and listening to us. There are programs out there, such as Salvation Army, such as Father Alfred's, that do offer that continuity of care, from walking through that door in a barrier-free environment to early recovery, to job training, to spiritual support, to return to housing. There are programs out there. We're small, we're larger, but we're still small in the big picture, and we need more of it, and it's very makes me very optimistic to see the city leaning in that direction and listening to those of us who've actually been on the front lines or who've experienced their own struggles with addiction.
Well, everyone, raise your hand if you're on Instagram. Daniel Lurie has lit this city on fire, man. If you watch his Instagram page, you cannot be anything but happy about living or working in San Francisco. And I want to say, like, it has been an incredible journey. I have some of my close friends here, Cedric Akbar, Craig Johnson. We've been in this fight for, a decade. And what gives me optimism is people like Dan Tsai and Kunal Modi call us, meet with us, talk about challenges on the street.
Get yelled at by you.
And actually listen. And it's, I think as a community, we can work together to solve these problems. Our city's come a long way. The energy is actually amazing. We have some work to do, but I think we can only solve it by being able to express our differences and to hear each other out. And I just want to thank Sally and St. Anthony's for this panel. Keith, it's always incredible to be around you, and I just want to say thank you, everyone, for showing up and being part of this discussion today.
I think I'm the last one on this. I think for me, I mean, I tell my team and every day, the team has done many, the city has done many incredible things, and yet you just have to look outside, walk the streets to know that we haven't done enough, and we need to try new things. And the biggest thing I feel is a deep sense of urgency every day when I wake up, where I'm out and about, that we just need to move faster and harder. And because again, 2 people a day are dying of an overdose, and countless more are in various stages of great challenge. And so what gets me excited is how we move a Titanic, but move it as fast and furiously as we can go to really support people on a path to better outcomes. And I don't know, most days I feel optimistic we can do it and do it well and do it fast. Some days when I walk the streets or get yelled at by somebody or whatever, it feels shitty. And then I get up the next day and I'm like, you know what, we can do, like, we have this moment, the Instagram account, yes, and everything happening in the city, and the sense that there's this moment of change and coming together even when not everyone's on the same page to actually tackle the drug, homelessness, behavioral health crisis in a different, more proactive way. That gets me excited every day, and that's when my spirits lift a little bit. So hopefully we can all do that together. We won't always agree every moment and everything, but I do really believe we can make progress in a way that we've never had before, and that's what we can do every single day.
Thanks. That's a great note to end on. Please join me in thanking this panel. This was really terrific. And now we're going to move to questions and answers. So you may have submitted some on paper, but we can also do some in the room. And we've got some roving microphones for that. Those are questions here. Yeah. Oh, okay. That sounds fine. All right. So we're going to give you my microphone. Announce it. All right. Okay, here's a good question for any panelist. How can the city and medical providers support family members taking care of a loved one struggling with addiction and also take care of themselves? Sure.
If you're able to, come with your loved one to see me as a medical provider. Our patients, it's so rare when a patient that I'm taking care of who has a substance use disorder shows up with anybody who cares about them. And that's huge when they walk into the room and there's somebody there. It's part of the, it's part of that piece of recovery that's called hope, right? Knowing that, there is somebody out there that really thinks that you can do this too. So bring them with you. And there's this great group called Al-Anon, if folks haven't heard about it, where you can discover as a family member that it's not your fault, right? Because so much of what you do is you bring shame to your own self, and that impedes the recovery of the whole family.
Thank you, Paula.
Terry?
Anyone else want to get in, or we can move to the next one? Okay, all right. So this is a good question, I think, for Dan. Will the scheduled 2026 Medicaid cuts affect San Francisco's ability to help people recover and stay in recovery?
So there's no question that the cuts federally and with some of the state budget cuts coming are going to be incredibly difficult for us. I mean, over the course of several years, we're forecasting eventually getting to, on an annual basis, several $100 million of cuts in our budget because of federal Medicaid and other budget cuts outside of the city. And so that is going to present enormous challenges. I think it's going to make us double down on investing in things that work and have outcomes. It will create that much more need to make sure we're measuring and holding our providers and the folks we contract with and ourselves, DPH as a provider, accountable for outcomes and performance. And I think it's very clear some of the very immediate priorities before us that we are going to make sure we put sufficient, smart funding against, and nothing about that will change.
Thank you, Dan. If you have a question, all right, we have a question right here in the front. You say who you are, please, when you ask. And I should have said also, a question is a short interrogative locution with a question mark at the end. It is designed to get information from others, and it does not include the phrase, in my experience. So, good question.
Hi, my name is Ayla Burnett. I'm a reporter with the Frisk. Wow, this is very echoey. Obviously, the Lurie administration, and even before, with people like Supervisor Matt Dorsey and Assemblymember Haney spearheading this shifted focus on recovery. I see that Lurie announced those three new sober living, I believe, or treatment programs. My question is, given the Housing First laws, where state money can only fund housing that doesn't require sobriety, how are some of these programs and this overall shift on recovery, how is that going to be funded? And do we need a legislative change in order to make that happen?
Well, we just got one, actually, and so Assemblymember Haney, on a bill that the mayor ended up co-sponsoring, AB 255, is going to open up about 10% of state funding to enable sober housing, and this is really about having more options across our continuum. Again, we have 20,000 beds across shelter, permanent supportive housing, another 2,600 of behavioral health care beds, and they, because of the state program, has meant that all of them had to be environments where drug use was acceptable. We think for some people who are on their path to recovery and self-express wanting to be in a sober environment as they're on that journey, we should be able to provide them that option. And so the mayor was glad to co-sponsor that piece of legislation. We're glad that it passed. Many people in this room were active in making it happen. And so that's a great start, and we're gonna do our best to implement it and create more options for people on a path to recovery.
Okay, directly behind, we have another one there.
Thank you. I'm wondering if you have noticed the extreme backlash against harm reduction, the different methodologies, and it seems to have gone rather extreme. And in light of that, what about harm reduction would you keep and what would you toss?
So I think when people talk about harm reduction, you talk to 5 different people, they have totally different definitions of what that means. 2, and this represents why I'm a fundamentally optimistic person, even for folks that are yelling at each other, when we get in a room, I mean, people are not going to agree at everything, but I think people generally agree. We want to find a way to quickly help people get into treatment, into services, and get on a path to better outcomes around that. There are a range of evidence-based tools that we need to use. What I mentioned before, though, is that we lack sufficient ingredients of a system that can quickly get people who want to walk through the front door somewhere into treatment, into services, into recovery that doesn't end suddenly after 30 days and they're back on the street. And we think we need a continuum of options, including recently, both the sober living situations, but also some of the other parts of a treatment system we've contracted with providers like the Salvation Army for, we think we need more recovery-oriented treatment options alongside other options that have been missing in San Francisco. And so I think there's more alignment than you would think when you hear people yelling at each other. And fundamentally, I believe everyone in this room and everybody here in the city and county trying to do this work wants to make progress. And I think there is a lot of common ground, and that's what I keep focusing folks on. But we have had real gaps, and we have pivoted and changed many of the elements of the system that we have not had before.
Okay, thank you. Right up here.
This is a follow-up question. We're talking about harm reduction, and Dan, I believe you spoke about the mother who saw 4 instances of drug use in rapid succession. I'm a father. My child goes to high school here in the city. I've experienced many of these things. And I want to ask the panel, what are we willing to do to reduce the harm and trauma that families are experiencing, witnessing some of these things play out on our streets?
And if I could just say one thing to emphasize what Kunal said, we are the Department of Public Health for the whole city. And that means we care for the health care of folks who are suffering from addiction and mental illness on the street. We also are the health department that cares for our communities, our kids. The Tenderloin here has an incredibly high per capita ratio of kids here right in the neighborhood. We also know undeniably from an economic justice standpoint, kids exposed to the things that you see all around have, adverse childhood events, incredibly long-term impacts on health, economic impact, and outcomes of that sort. And so when I think of our role as public health, I think too long the debate has been, you have to pick one side that you care about. We actually care about both, including the health of the community, which is why we care about public drug use, meaning not having public drug use and having folks move through treatment and recovery and having the streets be a healthier place in that context of community health as well. And so I want to say that on the record because that is a very, very, very important objective of the Department of Public Health. And I refuse to accept that we can only do one or another, and that in caring compassionately with dignity for folks suffering from behavioral health conditions means we have to let go of and trade off the health of our community. We have to do better around both.
Got a question right there.
I'm Kenny Chen. I have 2 questions. One, I want you to clarify, what is the program for those like homeless who say, I don't want help, I like it, okay, get away. And people who are addicts, what do you do when they say, no, I don't want treatment? I know those that want it come in to see Steve and maybe Paula, but what about those who absolutely refuse? That's one question. Second question, I'm troubled by those who are mentally ill and dangerous. I had a friend whose daughter was pushed off the subway in New York and died. And now we know Irina was stabbed to death. How does the city approach mentally dangerous people, and what program of interdiction is there?
Do you want to start on the first part?
We have, first of all, I'm sorry to hear about your friend's daughter. There's so many tragic instances that we're seeing every day across our country. We have thought about this in silos too often, and Dan sort of alluded to that. We're trying to look at a more integrated picture. This is not only social services, it's not only healthcare services, which are clinical, behavioral health, addiction recovery, but also law enforcement, and they all have to work together in tandem. It's not about being excessively punitive or lax. It's about just being practical and common sense. We need to continue to do a better job in the city of folks meet a standard of grave disability or clinical acuity where it makes sense that involuntary confinement and is consistent with the law, that we bring them indoors and get them the care and treatment they need. It's what any of us would want for a loved one who is in crisis on the streets and at risk of running into the street and getting hit by a car. On the other end of the spectrum, when there are people who do voluntarily want that care, we need to make sure it's accessible. So that situation that Dan described when he met someone at 10 p.m. who was ready to go to treatment, but we didn't have a place for them to go, we also have to solve that problem. And the reality is there's a lot of people on our streets today that are suffering that fall between those camps, that don't meet that very high standard for the legal threshold we've set here in California for involuntary confinement, but are not willing to go into care. And so one of the things we're very focused on is the way we've reformed street outreach to have more assertive engagement with folks and try and convince them to come into care. We're looking at some other models that we'll talk about over the course of the next year to help them get into a pathway for care. We're investing in our jail health services, so if someone does go through the criminal justice system, we're using it as a pathway to actually treatment and rehabilitation. And so we have to look at it in a much more integrated way. Every week, Dan and I, along with a few of our department leaders, sit with the police chief, with the district attorney, with all the players, because we recognize this is a multifaceted problem and we have to look at it holistically.
I would like to respond briefly, and I'm really sorry about your tragedy. I mentioned it earlier, I'm likely the only criminal on this panel, at least convicted. And I will say that what our city lacks is a public safety response. And, although prison saved my life, I don't wish it on anyone, but I will say we vote for lawmakers who pass laws. So we expect in a city like San Francisco that we would just enforce the laws on the books. Let's just review a few of them. You can't possess drugs, it's illegal. You can't be under the influence, it's illegal. You can't use drugs in public, it's illegal. You can't sleep on a sidewalk, it's illegal. You can't steal everything from Nordstrom's, it's illegal, and now they're closed. And what's happened in San Francisco is we victimized drug addicts. I mentioned it earlier, drug addicts are not victims. They've probably had some bad stuff happen to them in their lives, but they can heal from that. We've set the bar so low, we've made it, and that's the tragedy. I talked to the mayor a couple weeks ago and shared with him in his brightest of moments, it would be nearly impossible to clean up the streets because of penal code. My dear friend who runs the collaborative courts is in the front row, and I'll explain this to you. If I am shooting dope on Hyde and Leavenworth and a cop sees me and comes up to me, that's a misdemeanor. They're not going to take me to jail because of penal code 853.6. It's a cite and releasable offense. They're going to get out of the car, they're going to write me a ticket. I am never going to court, so I'm going to throw the ticket away. And then I'm going to walk down to Ross Dress for Less and I'm going to steal a bunch of stuff. And they're going to catch me and call the same cop. And he's going to write me another ticket for petty theft. So my addiction's going to escalate, where maybe I push somebody off the ramp at BART, or I hit Aaron with a baseball bat, and now I go to jail, and I have some warrants. And like any good defense counsel will say is, do you use drugs? And I got blood hanging out of my arms. Absolutely. And they're going to do a clinical assessment on me and diagnose me with substance use disorder. And then what happens? Under Penal Code 1001.36, I qualify for mental health diversion. So I have no priors, I'm not held accountable for my behavior, and I'm just walking around the city. And this cycle repeats itself and repeats itself. Now, I know Melanie doesn't agree with me, we have another lovely new law, which is Assembly Bill 1231, just passed. Assembly Bill 1231 gives judges unchecked power on felony diversion charges, child endangerment, felon in possession of firearms. I could go on and on and on and on. And I do want to say, I don't dislike the governor. He did give me a pardon. But I do think we need some leadership in the state where we begin to address behavior. We don't need to address addiction, just address behavior. We can't live in a society where it's an actual free-for-all. It's insanity. I've been on panels with my friends from Positive Directions, with Tom Wolfe and others, and we are all people that have broke the law our whole lives. And I'm going to tell you, the police saved my life. And if it had not been for the police, I may not be here today. And I'm so worried about people struggling with addiction in our city because I think it's nearly impossible to get clean here, or they make it so hard you need a PhD just to figure it out. Because getting clean is not difficult. You just have to stop getting loaded. And there used to be an intervention that was very useful. We used to get busted and go to jail. And was it fun kicking in jail? No. But it wasn't fun me terrorizing my family either, right? And so at some point, we need some balance in our response to the intersection of crime, homelessness, and addiction. And we have to stop letting the 4,000 people roaming our streets at night holding us hostage. I am very compassionate, and I don't want to offend people, but I feel like I must be honest.
Steve, thank you. Just want to get one more question before we run out of time. Is that okay?
Yeah.
Thank you. Thank you, Steve. And let's hear from the Reverend.
Yeah, I'm Richard Beal. I'm the Director of Recovery Services for Tenderloin Housing Clinic, and I got a question. Steve brought up about the number of people overdosing in permanent supportive housing. He said 25%, but it's 30%. I want to talk about another 30%, and that 30% is only 30% of the people in permanent supportive housing participate in support services. That is a problem. It's a problem because I think it should, my question is there any legislation that is going to be going forward to make it mandatory for people to participate in support services? Because people are knocking on the door. I know my case managers that work in the 25 buildings that we have, they knock on the door 25 times and 25 times they turn away. And then we still see people dying. And we paying 70% of their rent. They're only paying 30%. We're paying part of their rent. We're subsidizing them, but they're not required to participate in support services, and we just watch them overdose and die. That is unacceptable. We need to do something about it. What legislation is going forward to assist the people that is dying in permanent supportive housing?
I agree with you. That's what we're working on to do better. And I don't think we actually need a ton of new legislation. We need to operate our system differently. We've had this term low barrier for a long time in San Francisco, but it shouldn't mean low expectation because that's not compassionate. We actually want to support people with the services that they need to get better, but that's not what we've been doing in permanent supportive housing. Historically, it's not what we've been doing in our shelters. Again, sometimes, a house, a place to be is a critical first step, but it's not the only step. We need to layer it with structured programming, with clinical supports, with behavioral health care, with requirements that you meet with your case manager. And most people want that I meet. They want, and that kind of structure helps them improve kind of where they want to go. And so we are going to go through a process. Dan and I were just looking at data the other day. Two things. Every time in a building in our system of care, there's an incident, violence or overdose or anything, there's a critical incident report filed. And so we look at the critical incident reports in every building, not to be punitive, but to understand what are the challenges that are happening inside this facility. We also look at calls for service, 911 calls for service by building, and understand, again, not to be punitive, but to understand the level of sometimes disorder and chaos that isn't serving anyone in that community well. And so we're going to go through a process over the coming year. We will re-procure the whole portfolio of permanent supportive housing units in this city. And we're going to set new accountability standards. It's going to take time. I know we're all feel the urgency for change, and we have a big system of care that we want to transform thoughtfully. And so that's what we're going to do to make sure that we're setting those right standards, setting those outcomes, and partnering with providers who themselves, I think, would tell us the city hasn't done a good job of structuring the system and it's hard to operate. And so we have to be just as accountable on the city side, because it's easy to beat up on our providers, but we have designed a system set up to fail right now, and we owe them better as well, too.
Yeah, but Kunal, that's the Housing First Law, Senate Bill 1380, is driven by Welfare and Institutions Code 8255. So if you want to require services in permanent supportive housing, you are going to have to change the law because the law precludes you from doing that. So there should be legislative change.
We will, but I feel like we've used that as an excuse for too long. When I look at our HSH budget, it's a third general fund, a third Prop C, another local source, and then a third state and HUD. So things that use state capital or state operating, we're going to have to adhere to that. We should work on that legislative, but there's certainly a meaningful pool of units that we have our own local policy control over, and we can't be blaming the state 3 years from now if we're not getting our own house in order.
Yeah. Thank you so much, and thank you everyone for those questions. Let's acknowledge our panel here. Larry, did you want to come back up? I didn't know if you wanted to come back up, Larry, or not. Okay, so thank you so much for attending. I do want to let everyone know that you are all invited to Recovery Day, which is tomorrow from 12 to 3 p.m. at Boddicker Park. You can celebrate the recovery journey together. Also, that it's okay to linger. The event is over, but we have the room until 6, so if you want to chat, hang out a little, that's A-okay. So Larry here, do you have I don't know if you have a closing word, so. Okay, fair enough.
My only regret is I didn't give you your kudos. My favorite moderator. Thank you, Larry. All right. I'll see you. Yeah. Oh, there's Ellen. Huh?
You feel better? Sounds good.
Pleasure to meet you.
Thanks, Keith.
Hey, yeah, good to see you, Dan.
Put some on a 50-50 for being here to say it was groceries. BS. What are they supposed to do? That's just containment. That's not. Anyway, thank you.
Nice to see you again.
push him out.
Switch them up?
Just to push him out.
She was one of the co-founders of Free at Last. Yeah, you heard Free at Last. Yeah, David Lewis. Yeah, he's got out. Yeah. Would you like a copy? I will sign it for you. But I'm not even going to charge you for it.
I was looking at Stuart Rentals or whatever. What's happening now? Which is, they have like these giant Christmas balls. And like, they have like, so we're decorations that don't have to be long or don't have to like be, take up too much space. Yeah. I think so, it's not a problem that there's no. It's not. Like, yeah, hot boxes, whatever, which we can do judge.
Nice cover.
So when you on the plane,
I will. I love these. I love these.
yeah.
be about 200